Thank you for the invitation to speak at this very interesting meeting. So I'm John Benson, I'm a surgeon in Cambridge, and I'm chair of the working group on updating the auxiliary guidelines. So I'm going to give you an overview, really, of the recommendations. I'm not going to focus on a lot of the evidence in the interest of time. So it's a relatively sort of didactic talk. I'm just adjusting my glasses so I can actually see the slides. So auxiliary management has continued to evolve with a trend for de-escalation and a move away from blanket axillary lymph node dissection for biopsy-confirmed node-positive patients undergoing either primary surgery or neoadjuvant chemotherapy. So these updated guidelines will draw on existing international guidelines and generate algorithms which are tailored to local practice within the UK. So pertinent data has been summarized and specific recommendations derived with accompanying assessment for level of evidence and strength of recommendation based on the ESMO guidelines. So these guidelines will hopefully provide optimal strategies for auxiliary management in terms of timing and type of treatment, including imaging methods. So the guidelines largely relate to early stage breast cancer patients with stage 1, 2A and 2B disease. There is some stage 3A included in the guidelines, namely T3N1 tumours, but much of the published evidence, of course, focuses on primary tumour size of less than 5 centimetres. So patients with characteristics lying outside trial inclusion criteria will have management decisions based on an individual case-by-case basis, taking account of factors such as age, patient's preference, patient's comorbidities, and other clinical circumstances, and the size of the invasive component if relevant, particularly if it's more than 5 centimetres. And of course, I emphasize, these are guidelines, and every, decision on breast cancer patients has to be individualized to some extent. So where evidence is lacking and there's poor quality, we will seek expert opinion and consensus, largely for members of the working group. So this group is multidisciplinary. It has representation from surgery, pathology, radiology, clinical and medical oncology. And after we've issued the initial draft of the guidelines, these will be reviewed particularly from a radiotherapy perspective with specific input relating to the role of regional nodal irradiation in patients with 1 to 3 positive nodes, the role of auxiliary radiotherapy versus auxiliary lymph node dissection, and the additional benefit of auxiliary radiation over no further auxiliary treatment. And there will be doubtlessly various iterations of the draft document, and we will incorporate comments from all members of the working group. This will also include input from geriatrics as well. So the guidelines framework is based on sort of 5 principal sections: node-negative patients undergoing primary surgery, node-positive patients undergoing primary surgery, and then the neoadjuvant chemotherapy patients, an interesting section on omission of auxiliary surgery, and then techniques for auxiliary surgery. So evidence has been collected for each of these main sections, narrative summaries has been produced, and the corresponding recommendations have been made based, as I say, on the ESMO guidelines, which is level of evidence 1 to 5, and grading of recommendations. And I apologize for the quality of this slide. I won't dwell on it in the interests of time. So the